Thank you very much for your introduction, Dr. Stockman. I have to say, this morning I was sitting among the audience and listening to the presentations. And what really intrigued me about the Health Disparity Conference is the combination of basic science with qualitative and quantitative presentations, with different languages from different countries, with different accent and with like my accent, and I felt like this is really, truly a health disparity conference. So thank you for inviting me to speak at this conference. 2 months ago, when Dr. Stockman called me and asked me to present, I said I do a lot of work in the US, and I'll be happy to talk about my work in the US, especially with men and women and couples in the criminal justice system. And then after a discussion that took maybe more than 30 minutes, she said to me, no, I would like you to present your work in Central Asia. And then we start talking about the type of work she wants me to present. And we came up with this title, HIV in Central Asia, Multi-Level Intervention and Implementation Science to Address the HIV Epidemic Among People Who Use Drugs. First, I do work on multi-level interventions. I'm an interventionist. I'm a social behavior scientist, and I'm a social worker where I bring the community voices into my work. And in the last 4 years, I have been doing implementation research. So she said to me, let's bring the implementation science into your presentation. And I'm very, very committed to harm reduction programs, and I'm very committed to work with key affected populations, especially people who use or inject drugs. So that's the flavor of my presentation today. That's what you're going to hear today. I don't know how many of you have done work in Central Asia and how much you know about Central Asia. So I want to spend the first 10 minutes talking about the scope of HIV epidemic in Central Asia and to talk about progress and gaps. And then introduce you to the notion of multi-level interventions. And the multi-level, I want to start with a project called Project Renaissance, which is HIV prevention with people who inject drugs and using the couples as a unit of attention. And the second project is called Project Nova. It's a structural HIV intervention, and I call it structural, and you may argue with me at the end if it's structural or not. It's about microfinance and HIV for sex workers. And the third project, which I love it, and it's my only really implementation science study in Central Asia. It's called Implementation Science to Improve Treatment Cascade for People Who Inject Drugs. So I want to give you the flavor of moving from couples to working on structural interventions to talking about implementation science. And I hope you leave this presentation by getting the idea of what I mean by moving from couples to structural to implementation science. I don't know, as I said earlier, how many of you have been in Central Asia, but Central Asia countries consist of 5 countries: Kazakhstan, Uzbekistan, Tajikistan, Kyrgyzstan, Turkmenistan, and they have borders, as you see here, with Afghanistan. I work in all the three of the 5 countries. I also work in Afghanistan. Usually Afghanistan is included as Central Asia country, and other times it is not. But I do work in Afghanistan. I do work in in Kyrgyzstan, Tajikistan, and Kazakhstan. And today, my studies that I'll present to you mainly in Kazakhstan. Here is a view of, in fact, I see it from my office in Almaty in Kazakhstan. And these mountains that you see here are borders between Kazakhstan and China and Russia. It is important to highlight, as I mentioned earlier, that all these Central Asia countries have borders with Afghanistan. And as you all know, that Afghanistan produces 80% of the world's opium, 80%. And if you look at this number, 3 billion of money it got in 1 year as revenue from the drugs. And what's really important to know, and you may find out why I'm doing this work in this region, is the drug trafficking routes from Afghanistan to all Central Asia is huge, and I'll show you in a minute. And as a result, it's really drug use is spreading in the region as well as HIV. This is a map that shows the many drug routes from Afghanistan to all Central Asia. And there is a report that was published a year ago in UNODC showing that 30% of the drugs that trafficked through Afghanistan to all Central Asia stayed in the region. And unfortunately, the purity of the drugs that stayed in the region, in Kazakhstan or other countries, is not great, which leads to a lot of overdose and a lot of HIV and a huge problem in the region. But really, it's important to highlight here, as you see, that the drug trafficking routes from Afghanistan to all Central Asia, it goes also to Russia, to China, but also it gets into our country here through West Africa, as you see in this road. This is a map that was published only 3 weeks ago in the Lancet, showing that there are globally 16 million people inject drugs, 16 million. And in Central Asia and Eastern Europe, there are between 2 to 5 million people who inject drugs. It's huge. It's 1% of the population inject drugs in this region. In Kazakhstan, where I'm going to talk about specifically today, there are 127,000 drug users. In the same paper that was published in the Lancet a few weeks ago, also this paper provided an estimate of the prevalence of HIV among people who inject drugs. And you see here the prevalence is around 17%. But if you look at Central Asia and Eastern Europe, the prevalence rate of HIV increases to 25%. In fact, in some cities where I do my work, and you see in a minute, the prevalence rate of HIV among people who inject drugs increases to 30%. So what's happening in this region? Why people are become infected with HIV? Most of the infection come because of injection drug use. As you see here, in 51%, and 33% because sex trading or the partners of people who trade sex. And there is 6% because of gay men and men who have sex with men. I do work with all this population, but today I'm going to focus on people who inject drugs and sex workers. This is really an important map to look at. It gives you an idea of what's happening in Central Asia. The good news we know from UNAIDS that from 2010 to 2016, there is 16% reduction in number of new infections globally. And we ought to celebrate this progress. It's really great news. But if you look at the map in the green line, what's happening in Eastern Europe and Central Asia, there is an increase of 60% of number of new HIV infections between 2010 and 2016. The only region, in fact, in the world that we see this kind of increase of new HIV infections. And you may ask yourself, what's happening? Why we see this increase? And I will answer this question in a few minutes. The other piece is about a number of deaths or the rate of deaths among people in the region. We know globally, and we need to celebrate the findings showing that globally there is a reduction of 32% rate of death among people globally, which is great news. But if you look in the other side in the map, in the rate of death in Central Asia and Eastern Europe increased 38% between 2010 and 2016. Similarly, if you look at Middle East and you look at North Africa, there is the same increase, it's 42% increase of deaths. Clearly, there is an issue here. And the problem is many people who inject drugs or use drugs and sex workers and vulnerable populations do not have access to antiretroviral therapy. And you see in this slide, we heard this morning about the 90-90-90 and globally, we know that 70% of people who know their HIV status, we know that more than half access ART and 44% access have virally suppressed situation. Where if you look at Central Asia and Eastern Europe, the situation is totally different. Data from UNAIDS showing that only 63% of people living with HIV know their HIV status. And only 28% of people who know their HIV status are on ART. And of those, only 22% have a viral suppression. So it's really a very, very serious problem. And only 2 days ago, I was talking to my team in Kazakhstan, and I got data from the Republican Aid Center showing even people who inject drugs, only 16% of them, they have really are taking ART and they have virally suppressed. So what's happening in the region? This is really very sad story here to see only 10% of people who inject drugs in Central Asia and Eastern Europe have access, for example, to methadone treatment. In the city where I work, there is one small methadone program, and it is only for people who are HIV positive, and it's in the pilot phase of its inception. Like methadone, it doesn't work, and we need more pilot to show that methadone works. So drug users and people who inject drugs in the region do not have access to harm reduction programs. There are a lot of structural barriers that prevent people from accessing care. And when we talk about dealing with structural barriers, stigma is a huge issue. We heard about it today. Gender inequality and gender roles. Women usually are introduced to drugs by their partners. Women are injected first by their partners. Women are prevented to go to a drug and a treatment or harm reduction because their partners controlling the way they have to get the treatment. Criminal justice, policing, preventing people from accessing care, and discrimination, oppression, unemployment, and also the working conditions for sex workers on the street are really very, very tough that they cannot even prevent themselves from accessing any kind of treatment, and I'll talk about it in a minute. So when we talk about addressing the root causes of the problems, these are the issues that need to be addressed. Some of my interventions address some of these issues, but overall, our center in Central Asia is really committed to moving the focus from blaming the victim, focusing on the individual, to more addressing the social structural barriers. And I will give you some example of this work. And now you may ask yourself why I'm doing work in Central Asia, what took me to Central Asia, and I want to give you context to why I'm there. First, let me say that from 2004, I started learning about the region, and Columbia University, the president of Columbia University, decided to put money to invest in education and training to bring faculty and students from the region to teach them, to provide them scholarship at our university. And we work closely with the Open Society Foundations, and we were able to allocate funding. And I was selected to go and recruit the faculty and recruit the students, and that's where I started learning about the region. Currently, we have 100 graduates of our program. And because of them, we are in Central Asia, and we built our center there. The other piece that is important to highlight, after I learned about the region, and because of my commitment to key affected populations, and learn about drug trafficking, and learn about the problem there, and learn about policing, I decided that I want to invest and spend my time. I took a sabbatical and spend my time building the infrastructure and doing my work there. And then I convinced the president of Columbia University to provide us with funding to build the Global Health Research Center of Central Asia. And currently, we have 30 staff members working in the region. So with the help of the staff, we were able to convince the governments in the region, not only Kazakhstan, but all Central Asia, to provide us with resources and to work with us. I have to tell you, based on my experience and many years working there, there is no better than building infrastructure and working with the people on the ground than doing research and leave the place. And because of the vision of the team and the vision of our graduate, we were able to really embark on large number of studies and make an impact that we could evaluate the impact. So as a social scientist and with the head of social worker, I committed in the past 20 years, my work is on studying the spread of the HIV epidemic in Central Asia and other countries. But also I'm very committed to design, implement, adapt interventions, moving from efficacy to more implementation science, which I want to share with you. So the first study I want to talk about, it's called Project Renaissance. The name came from the drug users that we worked with, came from the people on the ground, and they decided that that's really an important name. It shows that there is a new idea that's coming to the place. A Project Renaissance was funded by NIDA for 5 years, and it's a couple-based HIV intervention with combination of overdose for people or couples who inject drugs. In our study, when we recruited the couples, we said it could be a woman or a man or both inject drugs. And in the study, the majority of the men, 99%, were injection drug users, and 65% of the women injecting drugs. You all know, I don't need to remind you, that most of HIV behavioral intervention, unfortunately, target the individual. We teach the individual, especially women, to learn communication skills, to learn assertiveness skills, to learn about their reproductive health, and empower them. We use the word empower them a lot, in fact, and tell them, go and deal with your partner. You need to convince your partner to use condoms. You need to use your partner to not to share needles. You need to use your skills. We teach you to do all these things. But we know, and we heard this morning, and this is another presentation, I can spend hours on it, about how this leads to violence by itself. So I decided in 2003 to start designing and implementing a couple-based HIV intervention. In fact, I have to tell you, the study section members thought I'm crazy. How can you bring couples together to talk about sensitive issues? But here, I did a systematic review in 2004 to look at what's happening with couple-based HIV intervention. And unfortunately, since the start of the epidemic, there were only 33 studies with couples. Most of our studies with HIV prevention focusing on the individual rarely bring the couples together. And when I looked what's happening in Central Asia, there were zero intervention with couples, and in all Asia, there were 3 studies. Even in the United States, if you look at what's happening with couple-based HIV prevention, at that time when I did the systematic review, there were only 12 studies. And we know that people are infected because they're together. So it's really interesting to see that how we ignore this approach in our science of HIV prevention. So Project Renaissance was adapted from a study that I conducted in the United States, and it's called Project Connect, and it's chosen by CDC that it's the best practices. And currently, Project Connect is disseminated in all United States, but in other countries. So I took this intervention and I adapted it specifically to the cultural context of Kazakhstan. So what was the purpose of the study? Is to examine the efficacy of 5 sessions on couple-based HIV prevention. And the outcomes of the intervention is to reduce unprotected sex and increase condom use, to reduce incidence rate of HCV, given we're talking about injection drug users, and incidence of HIV, as well as overdose. And that was the first study that included HIV, HCV, and overdose. So the intervention is about comparing 5 sessions of couple-based HIV prevention with overdose to a health promotion wellness intervention, which is a control arm, that has overdose prevention but doesn't have HIV. I could not deny overdose prevention from any person, so I included overdose prevention in both arms. I put this photo here with Chris Bayer. You may know him from Hopkins. That's the first time we introduced the study to the government of Kazakhstan, and we were concerned because they did not want the study to happen there. And it took us a while to convince the government that this is an important study. Here is the design of the clinical trial. As you see here, we recruited 300 couples, and randomized in the 2 arms, the 5 sessions of HIV risk reduction plus overdose and health promotion with overdose prevention. We followed the couples over time for a year. As you see in this figure, the retention rate in the intervention was quite high. We were really very pleased with the attendance rate. We also very pleased with the follow-up rate in both arms. And you may ask, what is this intervention 5 sessions that I'm talking about? First, let me say that the intervention is built on the WHO consolidated guidelines of how we should do HIV intervention, plus the intervention that I tested and designed in the United States. Basically, it's about teaching the couples together about problem-solving communication skills and drug risk reduction, sitting together and learning about gender roles and gender expectations, about reproductive health, about gender-based violence, the couple together to talk about it. And then a heavy piece on the couple together to learn about HIV testing, access to care, and access to treatment. And an important piece is about Naloxone distribution. In the intervention itself, we distributed Naloxone, and then we had a piece on overdose prevention, which we taught the couples together how to save lives, how to inject each other with Naloxone, how to teach other members of their family to help them to survive. And we integrated this intervention, Naloxone distribution, overdose prevention, as part of HIV prevention. I wish I can see more intervention on HIV prevention for people who use drugs that include overdose prevention. And you'll see in a minute how the couples were very excited about this approach. So the prevalence of HIV among the couple was, as you see here, 28%, which is really high. And what we found at 12 months, let me summarize the findings. We were very excited to see that couples in the risk reduction compared to the wellness promotion had 42% lower incident in unprotected vaginal sex with the study partners over 1 year, which is really, usually is very hard to introduce condom use in an intimate relationship, but this study really achieved this goal. The couples start using condoms together. And also what we found that couples in the couple risk reduction compared to the wellness promotion were more likely to use always condoms with each other at 12 months. We really were excited about the behavioral outcome of the study. In terms of biological outcomes of the study, at 12 months, we had 14 new HCV cases, and most of the HCV cases were from the wellness promotion arm. And so we looked at the data, and at 12 months, we found that there is a reduction of 69% in HIV incidence among participants in the risk reduction arm compared to the wellness promotion arm. So what we learned from this, that couples start using clean needles, they start even shooting, they start going to the harm reduction programs and get more needles in order to reduce the HIV risk behavior. So these findings were really very, very exciting for us. In terms of HIV incidence, at the 12 months, there were 14 new infections over the follow-up, the whole period. And we did not see a significant reduction in HIV incidence. As you see, the p-value is 0.2. However, over 1 year, there was 51% reduction in HIV incidence in the risk reduction arm when compared to the wellness. Again, it's not a significant, but it's 0.02. So in terms of overdose, this is very exciting slide that I want to share with you. We noticed that when we began at baseline the study, the prevalence rate was 25%, and at 3 months, there was a reduction in overdose in 5%, and then at 6 months, even more reduction. And still at 12 months, we had seen improvement, but went up a little bit. And you may ask yourself, what happened at 12 months? Unfortunately, the government of Kazakhstan stopped buying a naloxone, and the participant did not have access to naloxone. And we tried to bring from the US naloxone to carry with us, but was not enough for the participants. And still, unfortunately, the government doesn't buy naloxone. So in all our studies, we have to carry with us the naloxone. But only recently we heard that UNAIDS is going to be bringing more naloxone into the region. But that's why we see that the improvement was better at 6 months than 12 months. So in conclusion about this study, couple-based HIV prevention really has many advantages. And I've learned not only from Project Renaissance in Kazakhstan, but I have conducted 5 clinical trials in the United States and other countries. And I've learned from a scientific point of view that really couple-based HIV prevention creates a safe environment for the couple to disclose very sensitive issues, such as sexual coercion, extra-relationship affairs, gender imbalances. These are issues that if you train the providers to be ready to discuss these issues and create this safe environment, you can address them. The good news, Project Renaissance now is being disseminated in all Central Asia, now and in some Eastern Europe, in Ukraine, and also Project Renaissance is used in combination of biomedical ART, access to ART and ART adherence. It's really a part of a package that is integrated into biomedical research. Although it is behavioral intervention, but it has an impact on biomedical outcomes. So it took a while to convince the government of Kazakhstan and others to use this intervention. So we're delighted with the outcome of it. So that's really one approach of my work that I would like you to be exposed to. So I want to move to a structural intervention with sex workers in the region that I'm engaged in. This is a Project Nova. We're in the 4th year of the implementation of the project. And again, I call this intervention a structural intervention because it combines HIV with microfinance. I don't need to tell this group why it's important to focus on sex workers. I know you're doing a lot of work, and globally, we know that female sex workers are 14 times more likely to be living with HIV. And there is a very serious problem in Kazakhstan on sex work, but no HIV evidence-based interventions are available for this population. So Project Nova is funded by NIDA. It's a clinical trial study where we randomized sex workers in 2 different interventions. One is a brief 4-session of HIV, and one arm is 4 sessions of HIV and 26 sessions of microfinance. It's a lot of sessions, and I'll describe in a minute. And then we follow the participants in 1 year. The HIV risk is the traditional HIV risk. It's an evidence-based, working with women, and it's 4 sessions. One important piece I want to highlight in the HIV risk reduction is issue of reproductive health and gender-based violence are 2 important core components of the intervention. And safety planning in every stage of the implementation of the research is integrated into the core components. I think the innovative piece of this intervention is the microfinance. And people question me, can you really involve sex workers who use drugs in microfinance? Can you really help them to get outside sex work and work? And I respond, if their choice, the microfinance intervention is an option for women if they decided to get out of it. And the reviewers, when I wrote the grant, as well as a lot of my colleagues would say, drug users, they'll get the money and when you teach them about microfinance, and they will not get engaged in jobs other than sex work. So what is this intervention? Why I call it structural intervention? In this intervention, I have a component, it's called financial literacy training, and it's 6 sessions. And the purpose of the financial literacy is helping women to be familiar with banking and how the banks work, opening accounts in the bank, about budgeting, financial negotiation, saving, and paying debts, and prioritize their expenses. To tell you honestly, that was the most powerful thing you do when you talk about empowering women. They never been exposed to this kind of intervention. But I have to say, the fear of accessing a bank was huge. Many of the women own money to the bank and they don't want to go close to the bank. Many women don't want to go to the bank because their pictures are taken. That's the system in Kazakhstan. Right away, when you get to the bank, the picture of everyone, the photo is taken. So they didn't want to go to the bank. One important thing that structurally happened, that we included people from the bank to be delivering the intervention with us. That was a really very powerful piece. And the other piece of this intervention is called match saving. You may have heard about match saving. It's helping the women to save. The concept of saving was very strange for many of them. So we do match saving. If the woman saved $1, we match with another dollar. And all the match saving that they have, they must, it's a requirement to use buy equipment for their jobs. And we tell them the purpose of this intervention is to help you to understand your needs, to prioritize your need, and to save money, and it's your choice if you want to make less money from sex work and get out of sex work slowly. That was the purpose of financial literacy match saving. But an important piece of the intervention is teach them a vocation. We did a lot of work to ask them what they would like to learn. And basically, the women said they want to do pedicure, manicure, hairdressing, or sewing. So we gave them the choice to choose between the 3. So, and as I mentioned earlier, it's a 24 session. They have to go to vocational training 3 times to learn about a vocation. So to summarize the microfinance, it's a combination of financial literacy, match saving, with vocation and training. Here, what you see with the characteristics of the woman, I want to only highlight a few things. That these women, they have main partner, as well as are married and having children. So always in the intervention that we delivered, they were thinking about their lifestyle and their families. But also the sad part of their lifestyle, so many of them been arrested, incarcerated, use drugs, and the combination of what we provide them with the financial literacy and match saving and learning occupation with their lifestyle was very challenging during the delivery of the intervention, but they really got very engaged in it. Another piece, when I talk about a structural intervention, policing, that was really the major barrier of women accessing this treatment. So the good thing is that we work closely with the Department of Policing in the city, and we did the study in 2 cities. And also the government became so involved that they told us and they allowed us to train the police about this intervention. So also in our community collaborative board, we had the police being partner in this. I have to tell you, if you want to do such a study, the police has to be a partner in this process, and that was the most powerful thing. So we also had people in our community collaborative board from the ministry, from the health department, sitting in the same room with the police in order to deliver such intervention. So in terms of the biomarkers and of the women, I want to give you briefly to see that the prevalence rate of STIs is huge, 51%. And also we have found that 25% was the prevalence rate of HIV, and HTV 48%. And when we looked at condom use, again, you look at condom use, rarely women use their condoms, not only with their main partner, but also with their clients. It's almost the same, 21% and 24%. So here are some of the findings. I want to remind you that this is a study, we're in the 4th year. I'm not going to share the final outcomes because we're almost there. But I want to tell you a few things. The sad part, 85% of the women own money to the bank. And that was the major barriers for them to save money. And when we asked them to open an account, if we talk about much saving, they refused to open an account in the bank. So we came up with an alternative, an informal alternative, to open account in our office. So we had a box where women could save money at our office. Overall, 36% of the women saved money and used the money to buy equipment for their business. And what we found, we did a qualitative work to ask the women about their experiences, since I can't talk about the outcomes. And many of the women said the vocational training increased their confidence and ability to access employment, even not the occupation that they learn, but other even jobs. The majority of the women reduced their drug use and they start focusing on their health. And the majority of the women, which is amazing, I cannot share the outcome with you because we're analyzing the data, but the condom use increased tremendously with both the regular partner and other partners. And the final good news is that we were able to involve the government of Kazakhstan to open an NGO about training of sex workers in one of the cities that we completed the study. Now there is a center training sex workers on microfinance, occupational training, and also paying attention to sex workers. And we were able to work with this NGO, with the government to do it, and it's so exciting to see the changes that is happening. The police even don't go close to this setting. So there is really, in fact, changing in the norms around how we can and how and why we need to work with sex workers. But there are challenges. I can't deny the challenges that we face. Again, is the fear of regulation, fear of the bank, gender-based violence, and unfortunately, no domestic violence shelters or services for women there, and we're working on it. And many times the women wanted to learn, for example, pedicure and manicure, and because they're HIV positive, some of them, they couldn't do it. So there are challenges that we're trying to address. But overall, we were excited about the outcome of the research. And currently, we're looking at the final outcomes, but only to make you feel like if the study is going in the right direction, the outcomes looking really great. And hopefully next year, I can present to you the major outcomes of the study. So that's an intervention, and you can argue with me if it's structural or not. And I want to move to implementation science. You know now, as especially new investigators, and we hear a lot about implementation science. We need to do implementation science, and there is a movement which is very exciting for social scientists and biomedical researchers working with the behavior scientists, like people like me, to start doing implementation science. So that's really a true implementation study also in Kazakhstan. And I want to give you a sense of what I mean by implementation science and the outcomes of this research. But the main purpose of this research called Project Bridge, it's also in Central Asia, in Kazakhstan, being implemented. And it's about bringing HIV care into harm reduction programs. It's a huge thing. I'm not sure how many of you know that it's a huge in the region to bring HIV care into harm reduction care. So you know, or may you not know, that the only really harm reduction treatment that happen in Central Asia and Eastern Europe is needle exchange programs. That's all. Syringe exchange programs are around. For example, in Kazakhstan, when I do my work, there are 140 syringe exchange programs. However, only less than 50% of drug users go to harm reduction programs. And if you look at what's happening in harm reduction programs, basically they give them condoms and they give them needles. That's all what's happening. So my role in my study is really to bring HIV care into needle exchange programs. The other piece that is happening in needle exchange programs is there is so much pressure on the nurse, one nurse for tons of clients who come here, to do everything, to provide needles, to provide the condoms, to talk to the clients. And there are outreach workers who, in fact, they don't give them any money for transportation to find the clients, but their role is to go out and find the clients, and neither the nurses nor the outreach workers are trained to address the needs of clients who come to harm reduction programs. So I got funding from NIDA to come up with an intervention to improve access to HIV care in needle exchange programs. So we talked a lot about 90, 90, and 90. The aim of this study, the primary aims, is to focus first in the first and second 90, meaning that to increase of number of people who inject drugs coming to needle exchange programs, because there are not many of them coming. And secondly is to increase the number of HIV testing that's happening in syringe exchange programs, and to increase number of people who are linked to HIV care. So this study is to improve the first and second 90. And the secondary outcomes of the study is to increase initiation of ART and to improve adherence to ART. So that's the secondary outcomes. And we use a lot of implementation outcomes, looking at barriers of implementing the intervention from the individual to the staff to the agency and all the other structural barriers. And finally, we're looking at cost effectiveness of the primary outcomes. So these are the implementation science outcomes. How we are doing the study, it's a complicated design, but we're using a step wedge design. We are in 3 cities and in 24 syringe exchange programs. And in each syringe exchange program, there is 1 nurse and at least 2 outreach workers. And so we are training them, which we call it, you probably hear a lot about differentiation of services in implementation science. You heard it a lot in publication, at conferences. So we're doing differentiation of services, meaning task shifting, really changing what's happening in syringe exchange programs to deliver the best HIV care for people who inject drugs. I want to focus on 1 minute about the intervention that we're bringing. The first part of the intervention, it's teaching the outreach workers to teach the clients to recruit their peers to come to the needle exchange program. It's a social network strategy. Secondly is to teach the nurse to do rapid testing on site. Rapid testing was not available when we started doing this work. And the third one, which never happened, to teach the nurse to do case management and linkage to care. So that was another differentiation of services that we introduced. And finally is to teach the nurse how to link people to care. So here is differentiating the roles of the outreach workers with the nurse to come up with this combination of intervention, bringing people into the system, do rapid testing, link them into care, send them to the HIV care, and we also trained a nurse in the HIV care to be delivering case management to the clients who go from the study to this setting. So I call it differentiation of care because we elevated the roles of the syringe exchange program staff, the nurse, and the outreach workers. We're training the nurses in a new way of thinking and approaches. We're also training the outreach workers to recruit in a social network approach to bring more people into the system. And also we use technology, which is really very important. We created a video. When you talk about contextually relevant video, is a video about how to engage clients to come to the setting. We also created a WhatsApp communication where the staff communicate with each other about challenges that they face. And we also created an app sheet to collect data over time. That's really, I believe, that's a very, very critical piece, because we want to look at the outcomes on the agency level as well as on the individual level. This approach in implementation science is called type 2 implementation science, meaning that we look at the effectiveness about the client outcomes as well as about the agency outcomes simultaneously. That's called type 2. So we are interested in both at the same time. So how do we collect the data? Very challenging. We're bringing a new intervention. We're changing systems. We're looking at the system change. At the same time, we want to collect data on the clients and what's happening to the clients. We're interested in collecting data, what's happening with the systems. And we want to look at our primary outcomes, the first and second 90 and the third 90. So we created something called App Sheet. It's a Google-based application that can be run in computers or tablet or smartphone for data collection. And we trained the nurse to use it. We put this App Sheet in the clinic and we train the nurse to use it. And for each client who comes to the clinic, we give them a keychain with a unique QR code. And when any clients who come to the agency get this keychain, get the QR code, and the nurse works with the client and collect data about every service that is delivered to the clients. At the same time, the clients take this QR code with the keychain to the HIV care, and we also train the nurse in the HIV care to collect this data. So we're linking all activities for every client who gets into the system in terms of all these outcomes. So we have outcomes related to biomarkers as well as behavioral outcomes, which allow us to collect data on each client, but also in how we're changing the system. So both program and client level data, which really is going very well. We were very concerned about introducing this kind of technology into a huge system that they never used, but it's really going very well. But that's not the whole story about data collection. We're also collecting data from the government. Every 6 months, the government agreed to give us data on the 3 cities we're working on and every client who is tested for HIV. And we look at access to care based on the data from the government. And then because it's a type 2 implementation science and we're looking at program outcomes and individual outcomes, we have a longitudinal component where we're following up 600 clients and ask them about barriers of accessing to care and looking at the impact of the intervention. And finally, because it's, again, implementation science study, and it's hybrid 2 model where both the primary outcome for the client and the agency, we're collecting a lot of data on policy implication and changes in policy, because as we speak, every day we see new policies introduced into the system, and we need to capture the impact of these policies on our major outcomes. So because I'm coming here and I want to share with you some data, so I looked at the data only 3 days ago. And I want to share with you some of the outcomes related to whether or not we increase people coming to the system. So I looked at what happened pre-intervention, before we did the intervention, 3 months, and then post-intervention. And this only data from 3 months. We're seeing in 3 months after we introduced the intervention to the needle exchange programs, we see increase of 32% of people, new people are coming to the HIV, to needle exchange programs. So we see more traffic based on the intervention. And what we're also seeing, more people receiving HIV testing, rapid testing, there is an increase of 27% 3 months after we introduced the intervention. We're really so excited about more clients who were feared to come to the sites. We see them coming to receive services from syringe exchange programs. And another piece, another outcome that I want to highlight, if you recall that one of our outcome is to see new people coming that haven't been tested before, new HIV cases. And here, I want to share with you, when we did the study prior to the intervention, we had 39 people tested for HIV. Only 3 of them were in new cases, only 3. The other ones were old HIV tests. They knew their HIV status. But after we introduced the intervention, we had found 23 HIV positive cases, and 11% of them, there were new cases of HIV. They never been tested. So there is an increase of 48%. So we're really very delighted to see a movement in more people coming to the syringe exchange programs, more HIV testing, more linkage to care, and also we're seeing new cases in the community that are coming to the clinic. So we're really very excited about the preliminary outcomes of the research. So I give you a description of 3 studies, but I want to conclude by saying I truly believe no single HIV intervention offers a magic bullet. There is no way that one intervention, the couple or microfinance or the implementation one that I described would be by itself enough for people to stay healthy and linked to care. We need multi-level interventions. We need the combination of couple, community, and structural. And we need to be thinking for the basic scientists who are sitting here and don't believe strongly in behavioral sciences. Really, truly, we need the combination of the two. We need the biomedical interventions to be connected to the biobehavioral interventions. The project that I described, Project Renaissance with the couples, it's fully integrated in the biomedical research. It took a while to convince that it's important, but it's now they see the utility and the importance of it. The other piece I want to say that I introduced all the social structural barriers, and I truly believe if we don't focus on addressing structural barriers like stigma and other issues in delivering HIV care, there is no way we can address the HIV epidemic. So I'm fully committed to really moving beyond working with the individuals. And Central Asia and Eastern Europe, where I do my work, is a place, it's really a great place to deliver these kind of interventions and see the impact. Really, it's happening. And it's so important to convince not only the governments of the region where we work with, but the funding that to pay more attention to the funders, to social structural issues. We see more movement. The other piece I really want to see more the implementation science, taking evidence-based interventions and implement them in real-world setting. It's a tough work to do, but I think where we are with the HIV epidemic is that's the type of research we have to do. And thank you.
We have time for 2 or 3 questions. If you can use the little microphone to the side.
Thank you. Thank you for a very impressive presentation. So I'm really glad that you're highlighting the importance of creating all these different layers of interventions and creating a more multifaceted approach to reducing HIV incidence. My question is about your NOVA project and the NOVA project.
Yes.
And what your thoughts are on biomedical interventions such as PrEP among the female sex workers and layering it with the structural interventions, and whether that would be a logical and feasible solution for Central Asia.
First, let me say, unfortunately, PrEP doesn't exist in Central Asia at all. And we wanted to introduce it with our intervention as a prevention strategies for women, and we talk about it, but there is no way we can convince the government to do it. But I think it would be really an important and integral part of something like NOVA project to integrate PrEP with it. And we do it in United States. We have a study with African and Black women in the criminal justice system. It's called Project Worth, where we integrate HIV prevention with PrEP, and there is so much excitement for women to use it. The other piece, we integrated it with couple-based HIV prevention with men in the criminal justice system in New York City with their female partners. And it's so exciting to bring it to the couple context when we talk about helping women to introduce it to their partners in the context of the intervention. It's going so well that there's so much excitement to be talking. And I will encourage us to be integrating it in the prevention. But in the region where I presented, nothing is there, unfortunately.
Thank you.
Hi, thank you so much for that presentation. I was interested in the microfinance component of the female sex workers intervention. I think you mentioned that it was there to help sex workers come out of sex work. Was it considered that it could also be there to help improve their sex work conditions, like, I don't know, renting a room in a nicer neighborhood, which would allow them to get fancier clients or...
Thank you very much. First, let me say it's a choice for them if they want to get out of sex work. We tell them from the beginning, we're teaching you a new occupation, but it's up to you if you want to get out of it. But it's also up to you if you want to get money that we give you to use it to make your life better. But they cannot use the match saving to do other things than buying equipment for the occupation. That's part of really the study. But we heard that women are more empowered to find the right clients to go out with. They less likely to abuse because we teach them about safety planning and how when they go out with men and in the car to see if there are more people in the car and how they can protect themselves. So we talk about other issues to make their lives better. Absolutely.
And can I ask another one? The other one was about, in terms of the jobs that they were offered, I guess there's a timing issue, right? Because they don't have that many training sessions to learn a more complex job. But I was wondering if they chose those 3 jobs because it's the only jobs that they can think of or that are most available to women. And if, I don't know, like if they could aspire to something else by being exposed to it.
Yes, I always, this question comes up. I do the same work in Malaysia, and we had the same issue. We want to expose the women to other jobs, like we proposed to do like computer science or other jobs, but the women chosen this kind of jobs, and there are more opportunities in their job than other ones. But we give them the opportunity to choose other jobs if they want to.
Okay.
Absolutely.
Thank you.
Thank you very much. I have a question. You're using, it's wonderful to see, and there's so many integrated facets of care going on. We have a tremendous problem with even integrating different subspecialties of medical care. I'm just asking, what chances do we have outside? You know, how are we ever going to build things like this in reality that are going to be sustainable with community funding and public health involvement? I know New York is a very forward-looking public health department, and I wondered, as you're at Columbia, have you had some interactions with them so that they can use some of this?
You know, you're right. In New York, we're ahead of the game, and New York is the best place to do this work. And I'm heavily involved in similar work in the criminal justice system, and we work closely with the Department of Health, and we're really getting a lot of support, and we can implement these models in New York City. But I do similar work in Malaysia and in Middle East, in Jordan, and I do work in other countries. It's really very hard if the government are not heavily engaged and the community in the whole process. So it's very challenging. And if I weren't there for 10 years and having no center on the ground and people don't believe us, there is no way we can be able to implement these kind of programs.
Hi. First of all, thanks for coming to speak about your work. And if I can say on behalf of a bunch of colleagues here, we're huge fans of the work that your group does. So I had two questions. They're related. One is you spoke a little bit about the policing and policy barriers to, well, both as drivers of risk and also as sort of barriers to intervention. So, and you mentioned that there was some training that you had done with police. So I was wondering if there was any evaluation, or if even just sort of you can speak qualitatively about that. And also, relatedly, what kind of work have you done to try to adjust the policy structural environment? Because obviously a lot of these problems are driven by laws and other policies, and if that has been something that you'd considered and what barriers exist there.
Yeah, let me start with the policy issue. The policy issue that I am very committed to is accessing Naloxone into the country. And we introduced it to the government, we work with the government, and luckily I was at a meeting at UNODC, and I convinced UNODC to work with us in bringing Naloxone into the government. And as we speak, as a result of the negotiation with UNODC in Vienna and Kazakhstan, we were able to now, as a pilot, to bring nasal naloxone into Kazakhstan and all Central Asia. Mm-hmm. As we speak, we came up with an idea to link people who leave the prison into services to get naloxone, but also the beauty of the work is to change policies of the pharmacies to provide nasal naloxone. But the unfortunate piece is a demonstration study, it's a pilot study, but there is some movement in the government to engage in this project. They're not putting money, it helps, as you know, but it's some movement. So and we will continue to work in this area. The other piece from the government is gender-based violence, and to create they call it service for gender-based violence. It's like shelters. So we work very hard with the governments to start thinking about creating this kind of service, and I see it as a structural intervention in creating a center for sex workers in one of the cities with the support of the government, and it's working now. That's really another kind of policy somewhat changes. So it's a lot to do, and you have done work there. With the policing, you are the best person to answer about policing. It's very
I'm
complicated.
Just curious if
with the specific study, training is a narrow training specifically for the project. So we had to introduce the project. We find out that there are female police women that they were excited about it, and that's why we succeeded to get in 3 cities in Kazakhstan to involve them. But it's a narrow focus. It's about the project and not about the public changes, public policy changes. Yeah. But we need people like you doing work in training the police in Kyrgyzstan. Your work is amazing, and that we need to do it on a macro level approach.
Thank you.
So I have one more question. Thank you so much. I actually like, and I'm very interested in your couple therapy, couple interventions. And I think, do you also take both parts individually? Because I'm thinking some couples might be okay, and other maybe they, especially women who are in a relationship that they are not equal to the husband. Maybe they don't want to share everything in front of the husband. So to make sure that they have some space to not always have to share their issues in front of.
I like your question, and I can spend hours talking about it. But I started my work in 2003 with couples, and the first study was Project Connect, where we did right away bring the men and women together without preparation, and we realized it will be probably better first to work separately and then bring them. And then 3 years later, we came up with a study called Project Eben for African American couples. It's a multi-site study where we included 523 couples, and that's exactly what we did, is first separate them, prepare them, and then bring them together. Now I'm conducting a study in New York City with men in community supervision programs in the criminal justice system and their female partners, and that's exactly what we're doing. One session prior to preparing them to talk to each other. There is one issue that I built on it all these years, is the domestic violence issue. Would you bring couples who are living in severe abusive relationship in such intervention together? So my earlier work, I excluded couples who they said they are living in abusive relationship. And then I was criticized in my publications that why you're really excluding people who need the support. So I came up with one question to ask the couples if they're willing to come together, which is, do you feel safe to talk about sensitive issues with each other? And if they said yes, then they come together. CDC likes it. In fact, it's one of the criteria they're using when couple-based HIV prevention are used. But if the science behind the process of doing HIV with couples discusses all these issues about the different methodology of how you do it when with different target population to avoid conflicts like you mentioned.